Kia ora, my name's Margie Olds, and this is the Glenohumeral Gurus podcast. This is a podcast for clinicians interested in shoulder rehabilitation. I'm a shoulder therapist based in Auckland, New Zealand, and in this podcast I interview clinicians and researchers across the globe about their research and their clinical practice on how we can improve outcomes for people with shoulder pathologies. The aim is to learn, laugh, and try to work out how we can help people with shoulder problems. Enjoy the podcast. Hey, it's my great pleasure to welcome back Karen Ginn to the Glenohumeral Gurus podcast. Welcome, Karen. It's great to have you back on. And today's podcast is really around some of the scapular EMG work that you have published, and we wanted to dig into that a little bit deeper. Before we do that, can you share with us some of the highlights of your career? If you look back over the enormous contribution you've made in this space, what sticks out for you most?
In the research field you're talking about?
Yeah, or both, anything really. I'm just interested to hear, what are your proudest moments?
Oh, well, in the research area, I guess our EMG work looking at shoulder muscle function has been a bit of a highlight, and particularly coming up with some sort of theories about the mechanism whereby both rotator cuff muscles and axioscapular muscles stabilize the shoulder region. I suppose some of our clinical trials have been good as well for me. We looked at passive joint mobilisations of shoulder region joints, and for people with shoulder pain and shoulder stiffness, the evidence was pretty clear that the mobilisations were not contributing to the outcome, to the effectiveness of the treatments. And recently we just published a trial looking at capsular plication surgery for people with atraumatic instability, and the surgical procedure was really not contributing to the outcome for these patients. And I suppose that just emphasizes that what seemed to be doing it in these times was shoulder exercises, which leads me back to the muscles that we've been looking at in terms of what they do in normal shoulders. And finally, just from the muscle point of view, we did some work with frozen shoulder or stiff shoulder. These people had what we might call frozen shoulder. And what we found was that active muscle contraction was a major contributor to the stiffness. And I wonder if that's actually not the case in many shoulder stiffness situations in the clinic.
That it's a response, that's a response to the muscle guarding rather than the true pathoanatomy that we know about frozen shoulder.
Yes.
That's
at least for some people, it doesn't seem to be capsular adhesion. It seems to be muscle activity, perhaps we suggested in response to pain.
Yeah.
It's big implications for how you treat the shoulder.
Hasn't it? And just if we stay with that study, because that study is, do you want to just explain to people a little bit about how that came about, just quickly, if people don't know that research?
Yes, it was a master's thesis by Louise Holman, and we looked at only five people who had been diagnosed by a surgeon with frozen shoulder, and he had offered surgery, capsular release surgery, for these people. They'd had it somewhere between 9 months and 2.5 years. They were still in the painful, stiff stage. We confirmed that they had the active and passive restrictions. In fact, these people were all globally restricted, every direction significantly. They agreed to have their range of motion, passive range of motion, measured prior to their surgery, and then immediately after their anesthetic, we remeasured them again. So we're talking just a matter of hours between the two measurements. Yeah. We had a device where we could measure force when we were measuring external rotation as well. And what we found in these 5 people was 4 out of the 5 had pretty much full range motion following the anesthetic with no procedure at all. 1 didn't. They had significantly more range, but definitely not full range of motion. And so the explanation we came up with was that this restriction was related to muscle guarding perhaps in response to pain, because when we took away their pain and turned their muscles off, their joint was just fine.
Yeah, it has enormous implications, doesn't it, in terms of
does.
how we might be treating frozen shoulder and maybe a bit more of an understanding about frozen shoulder. Do you have any sense of who the guarders were and who the people were? Like, how might we tell? Do you have any ideas about how they might have been different within those? I know it's only 5 people.
The one that had the least gain in range had it for longer. That was the 2.5 years. I guess our thoughts were that if you had it for that long and you haven't been able to move that far, yes, you'll get changes in the connective tissue. And if we look at the way frozen shoulder behaves, it gets better in, what are we saying now, 2 to 3 years is the with or without treatment. I think that's still what people are saying. Well, and in general, most of them recover significantly to have a functional range.
Yeah.
A lot of them don't recover to full range, but perhaps that is the connective tissue tightness associated with their lack of mobility over a lengthy period of time. But certainly for some people, they do get full range of motion. And yes, interesting to see how that could happen when connective tissue collagen requires so much force to stretch it if it does happen to be adhered.
Yes.
So, and these people recover without any of that. So
yeah,
a lot about what we've seen with frozen shoulder sort of supports the idea that muscles may be playing a big role in this.
Yeah, it's a really interesting piece of work, isn't it? It really starts you thinking about what we know about frozen shoulder and what we don't know and what's still left to find out, I guess.
Yeah, we're often asked when we presented this material, they didn't really have frozen shoulder. Well, it's a clinical diagnosis and these people fitted all the clinical criteria. But the other thing I'd like to say is, we think it's something very unusual for the shoulder. Well, maybe it isn't. Maybe it's something like a listing back or a wry neck, a muscle response to pain, trying to stiffen, immobilize to protect.
Yeah, so interesting. So interesting. Anyway, let's talk then. Our plan today is to talk with us around the scapular function and axioscapular muscles. Can you share with us some of the EMG work you've done in that space?
Yes. So when we've been recording with shoulder muscles, we're always were in some rotator cuff muscles, some movers of the humerus like flexors, extensors, abductors, and some axioscapular muscles, or some people might call them scapulothoracic muscles. We were almost always in upper and lower trapezius and serratus anterior, and sometimes in rhomboid major. So my comments are related to those muscles, those axioscapular muscles, but they are by far the major bulk of the axioscapular muscles. And what we found when we were recording from all these muscles was that you got systematic increase in the activity in these axioscapular muscles as you got increase in rotator cuff muscle activity and the agonists, the movers of the humerus during whatever task we were doing. And this was highly correlated. So as you got an increase in any of the rotator cuff muscle activity, so you got a similar increase in terms of percent maximum activity in the axioscapular muscles. And we found that this was, in many cases, direction non-specific. So we would get increases in rhomboid major and the upward rotators of the scapula in a task where we were moving into some upward rotation. And it also happened when we were working isometrically. So that sounded a little bit garbled to me. So just to summarize again, systematic increase in axioscapular muscle activity, not direction specific. It was highly correlated with activity in the other muscles we were recording from. And it happened when we were doing dynamic tasks and we did isometric tasks. So it wasn't.
And you then measured, sorry to interrupt, but just so I understand, you then measured the relationship as you added weight to the task. Is that what you were saying, or?
Yes, most times we were doing things under various loads. So we tried, often with a low load, medium load, high load, or 25%, 50%, 75% of a person's maximum, and then their maximum. So as we added load, yes, we got that increase.
And you saw the same kind of patterning in terms of with the load, but the amount of activity increased, is what you're saying.
Yes, so the pattern was the same. If the rotator cuff muscle activity was going up and coming down, so was the axioscapular muscle activity. And in terms of load levels, as you went up, there was a significant, very high correlation with the increasing activity in the various muscles. They were increasing at the same rate.
And so you think that's then a response to stabilize the scapula? What's your interpretation of that?
Yes. So axioscapular muscles are really strong muscles. Yeah. And so, given that it happened when we were moving and when we were doing isometric contractions, and the pattern of muscle recruitment at the shoulder is the same, whether you're doing isometric or dynamic contractions. The pattern of recruitment is exactly the same.
And just let me dig into that for people, because when you said pattern, you mean the order of onset. Is that what you're talking about?
Not just the order of onset, but how they behave through range if we're moving through range. So they behave the same, it's the same muscle groups. And if we do it isometrically, just depending on load, we get exactly the same recruitment pattern. Of course, we don't get the change through movement.
Yes, okay. Okay. Yes. And so you saw that the same as with the load. As you increase the load, then you increase your cuff, depending on which way you were loading, I imagine. And then you saw an increase in your scapular muscles.
That's correct. Yeah. And so our interpretation was that these muscles were functioning to stabilize the scapula against the activity of scapulohumeral muscles, deltoid and cuff. In other words, those muscles, scapulohumeral muscles, have their origin on the scapula, which is a very mobile bone. And if you contract a muscle, I know we talk about their actions as being movements or something of the humerus, and they do that. But muscles aren't smart like that. They contract, they'll move either bone if they can. So you can move the scapula. I don't really know how to describe this, but basically moving it laterally, away from the midline. And so, we don't want that, because then the muscles can't function at the humerus as we want. So we have to hold it still. And so the axioscapular muscles, we call them the scapular stabilizers. And yes, I think that's what they were doing here. And I think that's where most of their power, their strength is utilized at the shoulder. So just like I argued that the rotator cuff muscles work to prevent translation of the humeral head by providing a counterbalancing force to prevent that translation, I would argue that this was telling us that this is how the axioscapular muscles were functioning as stabilizers.
So that the humeral muscles could be trying to pull the scapula away from the midline, and the other muscles are working to hold the scapula on the thoracic cage in some description.
And in whatever degree of rotation you need it to be in that range that you're working in at the time. Yes.
Did you ever, and I've talked a bit with Anne Cools about the difficulty of EMG work in a pathological population, but have you ever looked at patients with dyskinesis or not, that because there's a space there, isn't there? Because these people, their scapula moves for whatever reason in response to pain or the motor control or strength. Have you got any thoughts around scapular dyskinesis in this space? How might that work?
So firstly, no, we haven't looked at anyone because Anne is correct. It's difficult to be able to compare abnormal people with normal people, because to get activity levels, which you need to look at the pattern of recruitment as well as how hard they're working, you need to normalize the data. And our only valid way to do that is to a maximum contraction. And when you've got people with dysfunctional muscles and pain, you can't get that. So it's very difficult to do. So the answer is, all I'm talking now is sort of theory.
Yes.
If that is correct, that in fact the axioscapular muscles are largely responding to what the rotator cuff muscles and the deltoid, the scapulohumeral muscles, teres major is another one of these. So if they're largely responding to that, then perhaps they start to do the wrong thing when the rotator cuff muscles or the deltoid aren't doing the right thing. If they're responding to their activity levels, then perhaps it's, it's connected. And, scapulohumeral rhythm, the muscle groups and the bones are very connected. So what I would suggest is we see these abnormal scapular movements in people. That has implications for the shoulder joint in terms of the muscle activity. You can't position the scapula correctly. These muscles lose efficiency, mechanical efficiency. And whether it was the cause or whether it's the result, I wonder what's happened to these muscles at the shoulder joint. And I wonder if we get a better idea of how to treat it, but maybe the question of why the scapula is doing this, if we had a better idea of what things at the shoulder joint were doing as well, if we had a better understanding of the muscle, the muscle function at the shoulder joint. I guess what I'm saying is, I don't think you can interpret anything around the shoulder until you get your best idea of what's happening in all those muscle groups. It's like we recorded from all of them. It's how they work together that is the issue. And I think that would be a good way to go to try to understand how the scapula does these wonky things and how we might have some more inroads into treating it.
We talked a little before we came online about some of these patterns you were referring to, like a flexion pattern or an abduction pattern. Can you explain what that means? Because that's what I'm hearing from you here. How does that work? What are your thoughts?
Well, I think it is just the scapulohumeral rhythm that we talk about. But instead of just talking about the kinematics of what the bones are doing, then we talk about the muscles that are producing it. So a flexion pattern will say that you work your flexors, that is accompanied by an upward rotation of the scapula. And I would argue that you turn on the back of your cuff at the same time to a larger degree than the front of your cuff, back of the cuff being supraspinatus, infraspinatus, and teres minor. And so there's a pattern. If someone has a problem in flexion, it would give you what should trigger, I think, in our minds should be, it could be the flexor, it could be the back of the cuff that's more involved, it could be the upward rotators. Yeah. If we go into extension, it's the extensors, the anterior cuff, subscapularis, and downward rotators of the scapula. And in abduction, all cuff, abductor, and upward rotators. So it's that pattern. It's sort of the kinetics of scapulohumeral rhythm.
And so how can clinicians use that? Like, if we think about that as a philosophy of shoulder movement, how can clinicians use that information in the clinic? How would they translate that from your work into the patient they see in the clinic?
So I think for the shoulder, what we're going to do is give exercises. I think that's what most of us will be doing. I think the evidence is saying it's the most effective. So everything we should be doing, I think, should be giving us insight into muscle function. And so I think active stuff is the way to go. And I think active movements are very informative because we know the pattern that has to happen as we go, through range. We know which muscles will be turning on, when they should be when the life is getting harder for them, when they have to add in another function. So when they have to be stabilisers, do they have to do rotation? When does that occur? So if you look at active movements, then I think where people get their pain or their symptoms or where their pattern starts to go haywire, I think will give you some insight into which of what I think are the two main muscle groups, the axioscapular muscles and the cuff. I don't think the movers of the humerus, they just do their job. It's how the other muscles respond to that, I think, that is the problem. So it could give you an idea whether it's more an axioscapular muscle problem or it's more of a rotator cuff problem, and also which part of the rotator cuff might be more affected. So you can get an idea of where the rest of your assessment should go to confirm your hypotheses about, I think it's more back of cuff, where it's short in its mover role, its rotation role, for example.
Right, okay.
And then you can do some muscle tests. Our isometric muscle tests can be useful. However, you do a maximal test and you turn on everything. You turn on the mover, you turn on the rotator cuff, you turn on the axioscapular muscles. So it doesn't give you, it tells you there's something wrong, but it doesn't give you as much information as those active movements, I don't think.
Yeah. Do you have any thoughts around, just as we're chatting about this, do you have any thoughts sometimes in a patient that is grossly unstable in multiple different directions? I might load them as a enclosed kinetic chain, perhaps, and try to use or in 90 degrees of abduction, where I think their humeral head is sitting on their glenoid, and try to fire them, back from that old paper looking at dynamic control, where I could bring them on in the front or bring them on the back with my cones of movement. And I think about then the cuff working to stabilize rather than rotate. Do you have any thoughts about whether I should continue doing that, how I could otherwise use cuff as a stabilizer, not a rotator?
Yes. I don't know about closed chain. I mean, I can see your point. You're trying to increase that medial force, that muscles produce to hold the head centered in the fossa, and you're using body weight and gravity to do that. Yeah, if that helps to hold it there while you can train the muscles, I don't know. You've obviously had a lot of success with that, so I suggest it's useful.
It seems to be pain free, I guess. Sometimes I find, I try loading their internals and external rotation below shoulder height, and sometimes that's really painful, and I don't really get an entry point. And so when you were talking about the cuff as a mover or as a stabilizer, I was thinking, well, that's what I do. What else could I do in that space?
So you could do a flexion movement, for example, down close by the side. The humerus will eventually have to rotate to get into full flexion, but it doesn't do it early on. So if the cuff will turn on there, and it will be turning on as a stabilizer. And if you want to then teach it to know when to turn on and to turn off, perhaps you could do a slight flexion slowly and then backwards into a slight extension, where I would argue the cuff will have to change its recruitment pattern. And so you're training the coordination between the cuff, or, it's coming on as a stabilizer and it has to come on now as a stabilizer.
Yeah. I think about those really acute cuffs that are really sore, then that you're right, that is the isometric flexion that I've used thinking about that work, when you do an isometric flexion, I would be thinking more about the back of the cuff, and isometric extension, anterior cuff is what, just for the listeners, that's what we should interpret. Yeah.
That's what our studies would suggest. Yeah, well, that's what they're doing. Yes, that's what they're doing. But can I also say something about the 90-degree abduction position? So, at 90 degrees abduction, I'll just lower the camera a little bit.
You've got a great shoulder top on. We can really see your shoulder for those of you that are listening. But anyway, for those of you that
Please excuse the saggy triceps. So, we all think about, we go into abduction and it pulls the humeral head superiorly and the cuff has to hold it down. And I don't think there's much argument against that. I think most people believe that's what's happening. And I certainly think I would concur with that. But actually, it only happens when you start abducting, and the more you come up, I don't know exactly when it's a horizontal pull, but deltoid now is not pulling that humeral head up. It's pulling it in. And as we imagine the scapula going, I'm assuming the same thing's happening up here. So, if we wanted to look at the cuff, we could perhaps, I don't know if this would help, but take away a lot of its stabilizer role to begin with and get it to turn on as a rotator, maybe, I'm not sure. Or maybe start in that position where the whole cuff will be working here, by the way. Even here in this position, it's working, even though deltoid's doing something. But if we then go down a little bit, and so now we're getting a slight upward shear from deltoid, can the cuff cope with that? And your movements of something like I'm doing now, those sort of things, that's just sort of saying a little bit of flexion, a little bit more extension. So they have to adjust how they're working. I think it's all about recruitment patterning. And I think we just have to we've got to find graduated ways to train them both in their stabilizer and their mover roll. And if
Let's talk about that. Oh, so no, way you go. You
Well, I was just going to talk about throwing, okay?
Okay.
And it related to what I just said. This is how we throw. We throw, and you need to be at about 90 degrees abduction, or else you end up with shoulder problems, as far as I know from people who look at this. And what do we use as our accelerator? We use basically we use our subscapularis with some help from other internal rotators. In the most ballistic thing we do with our shoulder, I think we are using our cuff as accelerators and decelerators, and we're using our deltoid, our strongest muscle at the shoulder, to stabilize it.
Okay.
And maybe it relates to your weight bearing through the shoulder, where you are doing something like deltoid would be doing in that throwing action.
I wanted to head us into the graduation of the exercises, so clinicians could then understand how they could use that concept to graduate their exercises. Is it as simple as adding a bit of a heavier load, or you think there's more to it?
Oh, no, you can do it that way. The most common rotator cuff exercise is, TheraBand by the side into internal and external rotation. I still think it's the most common used thing. Every time you increase the TheraBand thickness, the load, you are increasing the activity in the axioscapular muscles. You have to be. So calling them rotator cuff exercises is only giving them half their due. They are scapular stabilization exercises as well, if you are holding your arm by your side. And every time you add load to it, you are gradually increasing their role as their activity levels. So it's a graduated stabilization exercise for those axioscapular muscles. But I think you just don't have to add load. I think it's an all right way.
One way, yes.
It's fine. But what about increasing complexity of what you're asking them to do? So if you not just turn on a rotator cuff muscle, a rotation movement, but what if you did it up into some abduction? So now you've got deltoid on as well. So more potential translation of that scapula. So now, depending on how high you go, if you don't go very high, scapula doesn't have to rotate. But if you go up, the scapula now has to rotate as well as hold against more scapulohumeral muscle force trying to displace that scapula. The way to gradually make the scapular muscles work as stabilizers is to increase activity in the rotator cuff muscle, in the scapulohumeral muscles, either one or a couple of them, or increase the number of them that you are using. And I suggest the second way is a good way, because it's starting to retrain the patterns more.
And so it will be a bit more functional loading, and that your scapular muscles would then respond to the load that you are having or experiencing in the humeral scapular muscles.
That's right. And then those muscles will have to coordinate to do their jobs as well. So they have to, the cuff has to coordinate with the deltoid, for example, to stop that upward translation. So, you are adding complexity to the task by making the muscles work in both mover and stabilizer roles, but at a load level or a complexity level that is challenging but achievable.
Karen, are there any other ways that clinicians could graduate their exercises? Is there any other than the load and the complexity of those tasks?
Well, if we're looking at the recruitment patterns, a way to challenge recruitment patterns or coordination maybe is to
Mhm.
increase the speed with which you do the particular task or the exercise. So
Okay.
that is, I think, if we're really looking at recruitment patterns as being a major contributor to problems at the shoulder, then load is a good way to do it, but speed is another good way. You're learning the skill of recruiting these muscles in the right role at the right time for the task that you're doing, and being able to do that with speed is important. And perhaps, another thing is to change the pattern that you want the muscles to do within the same exercise. So rather than just work a flexion pattern, maybe we work, as we talked about before, flexion going into extension, so that the patterning has to change within the exercise, almost like at a crossover point, like the
Yeah.
pattern change in a relay race. And the faster you can do that, the more skilled the brain is at recruiting the muscles that it needs at the time it needs it in the right pattern.
Yeah, because that takes me into some of those complex cuff patients that I see. Typically, I've isometrically loaded them, I've loaded them then through range, and then I've increased their speed, but only then typically in internal, external rotation. And I'm probably missing the boat there a bit because I could be flexing, extending them, and thinking about their cuff stabilizing in that way, as long as I brought them all the way back into extension, couldn't
Yeah.
I?
I think that's, what could be wrong with the cuff? It could be too weak. It could be not long enough. Okay, we
Mhm.
all assess those things. But could it be that it doesn't coordinate well within itself?
Yeah. Yeah.
To do its stabilizer role and its rotation roles, they do opposite rotation roles, and they work differently
Mm.
in the directions we move. So what if they don't know when to turn off? What if,
Yes.
and if you just train one pattern, they're learning to turn on, but are they learning to turn off when they need
Yes.
another pattern? And I
Yeah.
think that could be what's wrong with the cuff. It may not be nothing to do with their strength or their length. It could be that
Mm.
they're not being recruited appropriately. They're not coordinating well.
And do you have tips for clinic? So I've done, I mean, as you know, some things, palpating subscapular, switching on, switching off, switching on. Same with posterior cuff. But for me, that's been palpating, trying to give the patient like feedback there. Do you have any other tips? How else could clinicians train switching on and switching off?
Well, I think you just, if you were lying supine and had your arm in that position, and we often test rotation in supine
Mm.
anyway. So
Mm.
you think about that, going back into external rotation in supine is anterior cuff as a mover.
Yeah.
And then it comes up to the vertical, and right at that point, it has to turn off, and the back of the cuff has to turn on to take you down
Yeah.
into internal rotation. So what if they had difficulty doing that changeover? I mean, how could
Mm.
we diagnose that this was a problem within the cuff? Well, that might be a nice test.
Mm.
You know, and how would you, if it was, how would you train it? Well, firstly, don't load it too much, which says don't go too far back, don't go too far
Yes.
forward, because the load is getting greater. Do it
Yes.
very slowly until they can get through without the pain or the click or the stiffening that I think can happen
Mm.
there. Um,
Mm.
and gradually teach them to do that. And their task is not to go into range, not to do it fast, but to be able to switch from one to the other without the joints suffering somehow. I
Yeah.
personally don't like it to click at that time. I think it's telling you
Mhm.
it's not being stabilized properly. I don't know how valid that is, but any pain or any stiffness, I would be getting them to do it more smoothly. Just like I
Yeah.
would train a relay runner. You can't change the baton without dropping it. Come up, stop, hand it
Yeah.
over, take off, and then
Yeah.
gradually do it smoothly so you don't have to stop. And then gradually add load by going into more range. So you turn them on harder. If they turn on harder, they know how to turn off. So the other can
Yeah.
turn
Right.
on. And maybe interpret stiffness as not
Yeah.
active stiffness as their inability to sometimes think that, once you turn the cuff on, if it hasn't been that good at turning on, it's like it gets the ball and it won't give it back. It's like, I've got the ball now and I'm not giving it, I'm not going to turn off. So not only do they have to know when to turn on when they need it, they need to learn to turn off when they're needed.
And you had some other points I wanted to dig into around the throwing. You talked about being in abduction and winding back. Tell me about that. Let me understand that properly.
Well, you know much more about throwing than I do, but I believe that, to be a thrower, and I've looked a little bit at baseball. So, the most ballistic thing we do, I know there are other ways of throwing, but looking at baseball, the fastest thing we can do, they need them to be in abduction or a small arc there, or else we get problems. So in abduction, in that position, then deltoid is mostly producing a medial force on that humeral head into the glenoid fossa. It's actually acting as a stabilizer in the joint there, holding the joint in abduction and providing a force to compress those surfaces. And to do the accelerator, the muscles that accelerate the motion for a pitch are the internal rotators, particularly subscapularis. It works at 100% of its activity. Some activity, maybe about 50%, if my memory is correct, in latissimus dorsi, and a little bit of activity in pec major as well for the acceleration phase. And then, of course, we decelerate by turning on the back of our cuff.
Yeah, I was just thinking about that relationship between like concentrically accelerating and decelerating eccentrically in the cuff. How might that?
Well, they're mover rolls. They are mover rolls. That they are producing the movement. Are they stabilizing? Well, yes, maybe a bit, but you have a lot more subscapularis on in acceleration and a lot more posterior cuff on in deceleration. But deltoid activity doesn't change. And can you imagine? I can't imagine the translation forces being potentially created on that humeral head while you're doing these things. But what's the deltoid doing? Deltoid is holding the joint together with a compression force, and it's the strongest muscle we have at the shoulder. So there was a paper we did once, and it was called the sort of shoulder muscles role is task specific. We always think of the cuff as stabilizers and the deltoid as the mover. And I reckon there is an argument that for our most ballistic task, our throwing task, Rod Whiteley would say it's the reason why we became the dominant species, because we could kill those dinosaurs and everything without getting up too close, because we are accurate throwers. I don't know how accurate that is, but it sounds good to me. So, for that task, which may have been very important in our evolution, I would argue that it's deltoid that's the stabilizer, and that it's the cuff that is actually doing the mover or accelerator, decelerator roles. And maybe we could use that to help train shoulders that are not necessarily want to throw, but to be able to get better stabilization at their shoulder joint by utilizing deltoid while we train the cuff to do its job better, both rotation and stabilizer.
Do you have any thoughts then, because this conversation is making me think, first of all, distally into grip strength and the activity of the cuff, but also in kinetic chain and activity then of the scapula and cuff? What are your thoughts from either end of the spectrum?
I think you've just added more complexity.
Okay.
Yeah, and so you're working off a longer lever, doing things with the hand. I think obviously the shoulder bone's connected to the spine bone. They work together, and our activities are not just at the shoulder. But I think we have to be careful at introducing that too early, because it's more complex. And if I don't know. I mean, it might be the other way around, but I would suggest that when we're not getting responses at the shoulder that we want, we tend to sort of look further afield. And I would argue that it's not a bad thing to do, but maybe we should look deeper into the shoulder to see what it is we're missing there. And so we can get this part of the system working better, so we can add the complexity to what they need.
Okay, so if I understand you correctly, where some people would add grip strength or some people would add kinetic chain, you're encouraging clinicians to look deeper into what's happening at the shoulder rather than go proximally away. Yeah, is that?
I am, and I say that because I guess what I've observed in things is that we sort of go from quite simple exercises, relatively simple, nothing simple around the shoulder in terms of muscle activity, to then quite complex exercises without the steps in between. And I think if we understood what we were doing with our exercises more, we would be able to work out ways to gradually increase the load and complexity to allow the system to learn the recruitment patterns it needs to function normally.
It's a fantastic lens, isn't it, to come at it from a patterning point of view rather than to think then about, a typical strength conditioning response to load, response to forces point of view, I guess, which is my particular go-to. That's my background there. So it's really interesting to think about it from a different perspective.
I think we've always said it, scapulohumeral rhythm. Everyone knows what scapulohumeral rhythm is, but what it really is saying to us, it's talking about the coordination between the muscles that move and stabilize the humerus and move and stabilize the scapula, not just what the positions the bones are in. It's massive coordination that has to happen between those, and they have to because their activities are related to each other intimately. How hard they work and in what roles, depend on what other muscles are doing.
Yes. Do you have any final points for clinicians? Anything you think that you would like them to take home and understand more about how they should shape their exercises? I know you've got an online course for those people who wanted to delve into it. What do you think is really important for clinicians to understand about this approach and this way of looking at it?
First thing I would say is stop thinking that your exercises are either scapular exercises or rotator cuff exercises, because they're not. They're both.
Yes.
And, always you need to consider the system as a whole. If you've got a wobbly scapula, if things going wrong, okay, it might be the scapular muscles that are the cause, or it might be that they are responding to dysfunction in other parts of the system, like the muscles of the shoulder joint. Until you have a comprehensive picture of all of those things from your assessment, then I think you are you're missing the boat a little bit. And secondly, it's just not possible to do rotator cuff exercises without scapular muscles working. And I'd also say the scapula is really functionally not meant to do these things. I'm not saying you can't use those exercises. It certainly works those muscles. But actually, what those muscles are meant to do is rotate the scapula. And I can't do that. You can't do that. I'm sure there's someone in the world who can do it. But basically, the only way we can do that is when we move our humerus. That's telling you how connected they are, how coordinated they are.
Yeah.
And I think we have to keep that in mind. It is not one group working or the other. They're always working together.
Yeah, that's a really good reminder. Hey, well, thanks very much for your time, Karen. It's great, as always, to chat with you. So I really appreciate it.
It's a pleasure, Margie.
Thanks for listening. I hope you enjoyed the podcast and found some clinically useful tips for your patients in clinic. Please subscribe to the podcast and follow me on social media to keep across the latest releases of the podcast. Don't forget, if you need a shoulder brace for your patients, then check out our shoulder braces at flawlessmotion.com. And if you want to know more about assessment and treatment of rehabilitation of your patients, then check out the online shoulder courses at margieolds.com. Otherwise, take care, enjoy, and see you next time. Please remember that this podcast is for educational purposes for clinicians only and does not constitute medical advice. Please consult with a qualified health professional or contact me to book an appointment for individual assessment and treatment. Cheers.